We're pleased to have Craig Becker with us. He is actually the President, CEO of the Tennessee Hospital Association, and he is actually the Dean of Presidents of Hospital Associations in the United States, the longest tenured CEO of a similar organization. Started out actually in journalism, so he's had feet in a lot of different camps. He actually began with a degree in journalism and a master's degree in administration from Rider University in Lawrenceville, New Jersey. Started out working as an editor for the Wall Street Journal. Spent some time at the American Stock Exchange, so he's had a very interesting career. He's also served as the CEO of the Maine Hospital Association, and then since 1993, he's been the CEO of the Tennessee Hospital Association. We're honored and pleased to have with us Craig Becker.
Well, thank you, and I appreciate being able to talk to you tonight. I'm obviously talking about it from the perspective of hospitals tonight, but hopefully we get a little bit into talking about some of the politics that are going on in this state that might be of interest to you. One of the other things that I guess is my claim to fame is I'm the father of two boys who are both Eagle Scouts, and so I've had the opportunity to go to some amazing places and to put this poor old body down on some really hard rocks and eat a lot of bugs and whatever else. But one of the craziest things I ever got to do was go to Mount Rainier and climb that with my youngest son, and that was quite the story. But there is a story with that one, but I've got a better one that goes a lot closer to home. And those of you who have ever been to Raccoon Mountain, have you ever gone? Anybody ever go to Raccoon Mountain? Oh my goodness! Yeah, okay. I see a lot of people going, oh my gosh, yeah. Well, anyway, so I went in there with both my boys, and you know, when you go in and you go on this thing called the Wild Tour, which takes you through these crazy places. And let me just tell you, the guy who's 6'1" and my size should never go through a thing called the birth canal or loose change. It was kind of scary, to say the least, and I almost got stuck in the birth canal. So there was a couple scouts pushing me from behind to get me out. But when you get done with it, you all go to this big cave, a cavern in there, and it's dark. I mean, if you don't have your lights on. So anyway, I knew what was going to happen is that we had some younger boys with us, and the first thing that was going to happen is that they would just start, you know, whining and crying. And so I went to the senior patrol leader, whose name was Loaf. Now, that was his nickname, but if you ever saw Loaf, he was not a half a loaf. He was a full loaf. He was a big boy. He was kind of like me. And I said to Loaf, I said, look, I said, when the lights go out in here, these young boys are going to get really scared, and we're going to have to do something about it. But as senior patrol leader, I want you to deal with it, okay? And Loaf says, I got it, Mr. Becker. He says, don't worry about it. So sure enough, the light goes out. It's quiet for a little bit, and all of a sudden I hear this, I'm cold, I'm wet, and I want to go home. And Loaf says, right as quickly as he could, he said, Mr. Becker, he said, let me tell you something, your mama ain't going to come down here and get you. So that just brought the house down. Everybody laughed, and so, you know, I thought that was a really good way of breaking it up. But also, it's also kind of appropriate for us here when we start talking about healthcare and hospitals, because clearly our mama ain't going to come down here to get us. We're going to have to do whatever we have to do, and we're going to have to do it on our own. So we're going to be moving forward with a lot of different issues, and I'll try to just touch on them because I know it's probably not what is of great interest to you, but it certainly would be of something. But one of the things that we are certainly seeing is that it is a changing time in healthcare. We are definitely seeing some significant changes to things. And we were talking with Clark, and Clark, I said he's going to have flashbacks on a lot of this because it's really been, for the last 30 years, every year has been almost a disaster waiting. But I really do believe that there are some things that are going to be of significant changes in the coming years. And so let me just talk about the last election that we just had, presidential election. And I don't know what your politics are, and it really doesn't matter because that's not what I'm talking about here. But whatever you think about President Trump, he is at least going to be the great disruptor. There is no doubt about that. And he is going to be a change agent, and I think nobody really knows what that's going to be. And one of the problems that we have is that he still doesn't have his feet under his ground, nor does his administration. So that's a little disconcerting for some of us, and I'll go into that a little bit more. But one of the things that I've seen, at least, you know, I'm a student of history in addition to being a journalism major, is it seems like every 40 years this country goes through some kind of reset. And when you think about it, the first one I can think of that was a major one was obviously the Civil War, or the War of a Northern Aggression, as we like to call it down here. And that was that, you know, slavery ended. It was certainly the agrarian society in the South was totally disrupted and changed forever. Up north, just was super hot in terms of the industrial might going forward. So that was kind of the first one that I see. The second one, then, you roll that camera forward, and again, it was pretty peaceful. Things weren't really going on until you got to the turn of the century. Then you had Teddy Roosevelt, who ended up being the trust buster. He broke up Standard Oil, broke up a lot of the big ones, and that again was another reset for this country. And I'm sure that the people who lived through both of those and all of these changes, it was pretty traumatic for them, and they were probably very nervous about where things were going. So roll it again, you get to the 1940s. We had a great depression, and Roosevelt starts the progressive wave. It actually started before 1940, but it certainly was really full-blown by 1940. And of course, you had the Second World War that was another change for the country. Finally, you roll again, you keep going, and you get to the Reagan Revolution, which then started as going from the progressive area heading back into the conservative era, and I think it's gone even significantly more than probably what Ronald Reagan could have even envisioned at that time. And so now you're at 2016, and you have the trumpeteers, or you have the trumpet revolution going on now. And so again, we're in this terrible time of flux of what are we going to be when we grow up? Where's our mama going to come from to pick us up? Whatever you want to call it. And for us in the healthcare field, the worst thing you can have is uncertainty. And I think that's true with any industry. I mean, think about the other industries and what they went through. Airlines went through this, banking went through this. Everybody has gone, every major one has gone through it. And we've had a great run, frankly. We haven't had this kind of disruption in our industry until recently. And I think as I say, it's going to even get worse. But the uncertainty is what's going to really hurt us. I can tell you that we have a lot of really smart people that work in the healthcare field. And if you tell us where to go, you don't even have to give us the roadmap. Just say, I want you here. We will figure out how to get there, especially if you move the piles of money there. I mean, that's for sure going to make people move there. And so, but we're just not there yet. We're just kind of in this flux. Nobody seems to know what's going on. We've seen we had a secretary of HHS, Tom Price, who lost his job. So there's a lot of uncertainty there. Seema Verma, who runs CMS, which is kind of our big banker, as it were, she really doesn't have the power to do anything. Now we have a new guy who's coming in, Secretary Azar, who's comes out of the pharmaceutical industry. It's going to be interesting to see how that all goes. But one thing that we do learn, or we do feel that's coming, is that there's going to be more flexibility and ability for hospitals and healthcare to react, hopefully, a little bit more than they have been, because we are pretty hidebound, and also we are very much wrapped up in regulation. So let me just set the stage again. I think pretty much all healthcare is under the gun, and particularly for hospitals. For us, we're losing our 340B program potentially, which is a very big pharmaceutical. We get cheap pharmaceuticals so that we can give them to the poor. We think we're going to lose that. It looks like that's going to hurt us. Tax-exempt bonds in this latest tax issue is now going to be probably gone. You won't be able to use those anymore. Cuts to payments, which have been kind of going along slowly, I think are going to accelerate, and we're going to see a whole lot more in terms of the cuts. But the interesting thing in all this is that we're seeing the things are getting bigger. A lot of our systems are getting bigger, and I'll talk about that in a little bit. But the profits, at least in the big systems, are still fairly robust. They're still fairly fairly heavy. So, but the rural hospitals in this state are the ones that are really suffering the most. We've already lost 8 of them. We lost 8. We probably have 3 or 4 more that are on the verge of closing, and it's just that probably is the thing that worries me the most, because if you live up in Jellicoe, or if you live somewhere in the real boonies, I can tell you right now that is very important for you to have a hospital, particularly if you want to keep your businesses there. So that's one thing that's really troubling to me. Pharma also has their own issues. I mean, certainly the high cost of drugs and their profits are causing them. They're fighting back, interestingly enough, pointing the fingers at hospitals and saying we're all the fault. And it's like, we're buying your drugs. We're not the ones that can do it. But pharma is certainly the ones that are trying to say that it's not them. Look at the other guy. Insurers, another one. Always, every day, seems like the administrative burdens that they place on providers and just trying to chase the dollars is crazy. They hassle their patients and their customers with lots of paperwork, and they are making some fairly significant dollars themselves. I mean, if you look at what United Healthcare makes in a quarter, it's probably what a lot of maybe perhaps 1,000 or so hospitals would make in that same time frame over a year. Doctors, they're seeing cuts to payments. The administrative burdens are starting to burn them out. Certainly, a lot of them we're seeing moving into administration in hospitals. They're giving it up. They're working for insurance companies. They're doing anything but having to deal with the paperwork. And a lot of them are now throwing themselves into the arms of the hospitals. The hospitals are now hiring these physicians, doing it a whole lot better than we did back in the time that Clark was playing in this sandbox. But it really is a different world in terms of that way. The independent physician as a onesie or a twosie is probably over. It's going to be, you either have to be in a large group or you're going to have to be hired by a hospital in order to make it work, because the administrative burdens are just too much. And frankly, we're all to blame in this. I mean, nobody is working together. Everybody's trying to go down their own track. There is plenty of money in this system. There is no doubt about that in my mind, and I think anybody else that you would talk to, even privately or publicly, will tell you that there is just more money than we need. But between the administrative overheads that we have and some of the profits that are out there, that it's just not working too well for us. So basically, the healthcare doesn't wear the white hat anymore. And, we're all viewed as too expensive. It doesn't matter whether you're talking about insurers, hospitals, doctors, or whatever. We're all considered too expensive, particularly for the governments, whether you're talking about state or federal. Federal government sees this just keeps growing and growing. If you take a look at the state level, the amount of money that goes into the Medicaid program in this state, they feel it could go into whether it be education, roads, whatever, economic development. So there's a real time now where everybody's kind of said enough's enough, and we're gonna make this stop. So the question for us, I guess, is how do we go about being part of the solution instead of being part of the problem? And then obviously you have the media dwelling on the negatives of it, and some of it's well-deserved. I mean, we play so many financial games. I mean, anybody who's ever gotten an EOB, and it just drives you crazy because you see $10,000 on there. The hospital may have gotten $1,200, but it doesn't matter because it says that's what the hospital charges was $10,000, when really the only thing the hospital got was $1,200. So, and I cannot get any of my CFOs in the hospitals, and I know I'm speaking to financial people here, but it is their black box, and they are going to play in that thing, and they're not going to let it go. So it's very interesting, but it gives us really bad PR. We focus way too much on sick care, and this is probably, if the revolution is going to come, that's the thing that's going to have to change. When you think about it, we get paid. This is where the money comes into. When you think about it, we get paid for everything we do in that hospital, and for every paying customer that we can get into that hospital. Now, wouldn't it be neat if somehow they said, okay, we're going to give you X amount of dollars to take care of a certain population, and you know what's going to happen? All of a sudden, that thinking is going to flip. That CEO is going to know how much money he's going to have or she's going to have in the beginning of the year, and they're going to work to make sure that people stay out of the hospital. Not, and I don't mean that in a way where they're going to say, we're going to deny you care, but we're going to try to keep you well. We're going to try to keep you in the most appropriate care setting, and it might not be in that hospital. And maybe you didn't need that surgery, or maybe you didn't need whatever. So it really is, right now, the incentives are just totally screwed up with the fee-for-service system that we're in. And one would think that this would be easy to do, but again, like I said, if all those individuals that we were talking about, there's a lot of money still floating around in there, and that's what's got to change. Congress and the states really now view us as a drain on the economy, not necessarily an economic engine. Although, you know, if you go into the rural areas, I can guarantee you that they are probably the hospital is the #1 employer in there, and probably the spending the most money in that particular community. But for whatever reason, it just does not resonate with our legislature. And so, you know, they figure that, again, we're taking money away from other things that they think are very important. So let me talk a little bit about what the views, I think, that the policymakers are right now. And, you know, the one thing I did agree with President Trump on was that who knew healthcare could be so complicated. You know, anybody who ever walked into a hospital or worked in a hospital, I guarantee you would know that. And there's really no consensus on how to control costs. And part of it is because it's so complex, too many moving parts. And I just tell you, you know, one of the things you know, everybody wants to look for that easy fix. And in this state in particular, I mean, our legislature always says, well, we need to be more market driven. And the Congress even says we need to be more market driven. Well, let me just tell you, when right now 83% of our revenues come from either Medicare, Medicaid, or no pay, people who don't pay at all. So when you got 83% of your revenues are coming in that are already, you know, it's told how much you're going to get paid, you don't have any opportunity to negotiate anything, and you're working on the margin of 17%, it really is hard to imagine how they can make this thing into a market-driven entity until they really let the market take over. Stakeholders are clearly unwilling to give up any of their piece of the pie. I mean, we've seen that time and time again. And it's now even permeating down into the individual hospitals. The pie has gotten much smaller, and the table manners have gotten much worse. So we are fighting that battle as well. Washington is really change adverse, and you know, I went in and I talked to Bob Corker. I've known him since he was the finance commissioner in this state, and I can guarantee you, probably on 90% of the issues, I'm on the other side of where he is. But I really respect the man because he really has the interest of the country at heart, particularly right now. But the last couple times I went in to see him, you know, he kind of came in and slumped in his chair, and he looked at it, he says, "Do you want the truth?" And I felt like there was a few good men, you know, any minute now he's going to say, "You can't take the truth." You know, that was the next thing that was coming. And it was kind of it, you know, it was like he said, hey, slam, bam, 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 bam. But then he would say, he said, so how are you going to fix this? So I kind of went through the litany of things that I thought needed to get fixed. And he says, that's what the Democrats say all the time. He said, so give me something out of the box. So I said, well, how about single payer? And he said, you are a communist. But they really are, you know, they're looking, Congress is looking for the simple solution. They always are. And I don't blame Bob Corker or anybody because they've got so many things on their plate, but somewhere along the line they're going to have to sit down and take a look at this from a purely analytical standpoint. Take a look at whose ox are you going to gore, and there's going to be a lot of them to be gored, and they're going to have to take that profile and courage to make it happen. On the state, right now, this is the most bizarre thing. They talked about, as soon as Trump was elected, they said, well, you're going to have more flexibility in the state. So I've talked to obviously the head of the TennCare Bureau quite a bit, and she keeps saying, we don't know what that flexibility means. We don't know what kind of flexibility we're going to have. So they get all this this kind of uncertainty again, and they're not going to make any changes because they don't want to get out on a limb and do something and then Washington turn around and smack them back down. So what this means is you get frozen in your old ways, and that's kind of where we are right now, which is a real problem. Nobody really wants to make waves in the state, and that's going to happen. One of the other things that didn't happen is we did not get expansion. We did not expand our Medicaid program, which would have covered probably roughly 400,000 additional Tennesseans who were uninsured. And these were people who were working poor. These are not people, I kept hearing from folks saying, these are deadbeats. Well, I can tell you that 38,000 of those are veterans, people who fought in Iraq and didn't have an injury, didn't have any war-related injuries, didn't have enough time in the saddle, and they can't get coverage. The most of these 400,000, when you take a look at them, they have at least a primary or secondary diagnosis of behavioral health, some behavioral health issues, whether it was drugs or it's just mental problems, and there's no way that they can get the services that they need to go forward. So that was one of the things that was really kind of disturbing to me, that we could not make that happen. But again, when you're going up against the Koch brothers, it's really hard to beat them and their money, particularly in this state, which is very magenta red. So marketplace will control costs. To talk about that, I said that's great, but when you got most of your money coming from the federal government, it's kind of hard. And so, there's no better alternative that's been given to them. And so one of the things that we're doing at the association is, I have our folks are, and Clark can tell you this, you get into a board meeting and, there's lots of gnashing of teeth and throwing of things, and then finally we kind of get down to it. And what we got down to was the fact that we've got to be part of the solution. We've got to come up with some recommendations. And so what we're going to do is have probably about 5 different pilot programs going on in the state, running the gamut from whether it's a global cap. There's a couple of entities that are hospitals that want to do this, systems that want to do this. They'll take the risk, they'll take the money, and they'll provide the care, and they're already oriented towards the community, which is what I talked about. And I think that's probably our answer in the end of how we're going to get our arms around this. Another one is talking about standardization of care. Why do you have 7 different hips that you use to put into an individual, and why do you do it 20 different ways when it's already been proven by even your societies this is the best way to go about doing it? And doctors always yell at me and say, that's cookbook medicine, but when I bake a cake, let me tell you, if I don't follow the recipe and I put a cup of salt in instead of a cup of sugar, I guarantee you it's going to be a bad outcome. So, and the hospitals that have already started doing this, and I give a shout out to UT Medical Center, they've probably the most farthest along on it. They basically have seen, one, better outcomes. I mean, people, less infections, less problems post-op, and they're actually saving money. And basically what they did is they went in on the hips, they went into their orthopods, put them all into a room, said, you're not going to come out here, you can't even go out to pee. I'm just telling you, you're going to get down to 2 hips. That's it. We're not going to do 5, we're not going to do 7, we're going to do 2. You pick them, you tell us which ones you want. Well, the savings of that alone was almost in the millions of dollars. So, I mean, this is the kind of thing that it's not rocket science, but it's really stuff that it's really hard to make, particularly the medical community, move. And I can tell you another story that, aspirin, they always say aspirin onset of a heart attack. That was 20 years ago that came out with that. The cardiology group came out. It's just been in the last 5 years that it's really taken off where people are at, where physicians are actually doing it. So, we've got to get out of our hidebound way of things as well. So let me talk a little bit about the election coming up. I'll diverge a little bit, some of the things that are going on the state level. When you get down to it, the gubernatorial election is the big one, obviously. And right now we have Diane Black, who is a congresswoman from up Murfreesboro way. She has the highest approval ratings and probably the highest name recognition in the state. Randy Boyd, from Knoxville, who's got an equal amount of money as Diane Black does. So money is not going to be a problem for either one of those candidates. Beth Harwell, who was the Speaker of the House, she's running. She also has fairly high name recognition. Bill Lee, who's from Franklin, not so much. And then there's Senator May Beavers from down in Wilson County, who is probably the furthest to the right of all of them. I think Randy Boyd, Beth Harwell, and Bill Lee probably are moderate, where I would go with moderate Republicans. Diane Black is really a moderate at heart. I've known Diane for a long time, but she feels like she has to go so far to the right just to make sure she can get out of the primary. So it should be interesting to see. But this state, as you well know, I think does not, at least on the state level, doesn't usually elect hard right people. So it'd be interesting to see how that goes. On the Democrat side, you got Carl Dean, who was the mayor of Nashville. He has the highest name recognition among the Democrats. And then Craig Fitzhugh, who is was the minority leader in the House from Memphis area. And I think he's banking on that he's going to get most of the Democrats over in that area to help offset some of the losses he's going to have certainly in Nashville. You know, somebody asked me to handicap the race. I guess it's down to me it's down to Diane Black and Randy Boyd. But let me just give you another story on this before you start taking anything I say to heart. And that is in 1973, I was a newly minted journalism guy working in New York City, thinking I was pretty hot stuff. But anyway, I was down at Asbury Park with a bunch of my friends. I was living in New Jersey at the time. Down at Asbury Park with a bunch of my friends. We go into this bar, and this band is playing. I'm going, oh my gosh, this is the worst band I ever heard in my entire life. And I said, come on, let's get out here and go to the next bar. Well, the bar was Stone Pony, and the band was Bruce Springsteen and the E Street Band. So that just tells you how, don't go with me, don't go with my stock picks either. So, but I'm just saying that Diane Black and Randy Boyd are probably the two, because of the money more than anything else, which is what it takes. We have right now the announced candidate on the Republican side who has any kind of cachet is Marsha Blackburn, and she's actually my representative. She's been in Congress for a long time. She's been chairman of the subcommittee on commerce and insurance. So she's certainly got name recognition. Now the one wild card on all this, there's a minor Democrat who's announced, which was kind of a throwaway. But the wild card in all this is that Phil Bredesen, former governor, is talking about running. And you know, I keep hearing from people who should know that he's definitely in. And when you think about it, that when you have a non-presidential election year and when that person's party is in power, usually it benefits the other party. So in this case, Democrats should be more. Now, the wild card in this thing, in this state, is that we are such a magenta state. I mean, we are so red that right now, but you know, we were 25 years ago when I came to this state, we were almost all Democrat here. So, you know, go figure. We can go back and forth. I think most Tennesseans, particularly on the state level, vote for the person than they do for the party. But it's going to be an interesting election to say the least. So let's talk going back to it again, to the national and state perspective. Here's what I see. It's coming down the pike for you all in healthcare. Anybody who wants to know what's going on in healthcare. The Congress is going to pass what's known as a version of the Graham-Cassidy. This was after they went through all the machinations on trying to repeal and replace Obamacare. They failed. And then Graham-Cassidy came back with one that was very interesting, but it still had some bad things in it. And I think there was fatigue, healthcare fatigue, so they just walked away from it. And it didn't pass. But I believe that it will in the future. I mean, it's going to come back. There's no doubt about it. So this is the blueprint, and here's some of the things that are in it. Capitation or block grants, that's what they're talking about. They're going to come to the state. They're going to say, okay, for Medicaid, this is what you get. We're going to give you X amount of dollars. The amount that they were talking about originally was they were going to front end load it with give you more, but the back end, when you got out to 2026, which when nobody is going to be here, it was going to actually pretty much crater some states because it would just cut it so much. So anyway, then the next thing is the state flexibility. I had a chance to talk to Larry Martin, who's the finance commissioner, and I said, you know, if you get this flexibility, you're going to have to make some really hard decisions that you might not want to. And he said, yeah, I know. He said, I'm going to have to tell people that you can't have this drug, or you can't go to this, physician, or you can't. So they may not want to get what they wish for, but they're going to get it. But I'll tell you the one thing that they really need to get their arms around is certainly the pharmacy piece to this. It's pharmacy now. We spend more on drugs in this state for Medicaid than we pay our physicians. And it's rapidly approaching what the hospitals even get paid. So it's really getting to be a problem. And, pre-existing conditions could go out, which really would be a problem. But anyway, cuts to hospitals are going to continue no matter what. We haven't had a raise in the Medicaid program in over 17 years. So it's going to be interesting to see how that plays out. A couple other things. We have, I think it's called the provider assessment. And back in 2010, when Phil Bredesen was governor, the recession was in full swing, and the state was out of money, and they came to us and they said, look, would you tax yourselves, hospitals, and we'll take those dollars and we'll take them up to Washington, and we'll get paid our match and bring it back down, and we'll keep you whole. We won't say you can't have, you can only have 7 days in a hospital, you can't have only so many office visits, everything. And so we did. We basically, at that time, we taxed ourselves to the tune of $352 million, and now it's up to $452 million. So we're about $1.3 million of the TennCare program. And that could absolutely go away because it's been a strictly voluntary thing among our hospitals, and some of them are getting pretty tired of it. So right now we don't have too many losers, but the day could come when that would happen. So watch for that. If that ever happens, then the end of the world is coming for at least the hospital side of things. We're going to see a lot more consolidation in this state. We've already seen it with Wellmont and Mountain States up in the northeast Tennessee. It actually runs, their system is going to run from the southern part of Virginia all the way down to Greenville. And in order to get that, the state had to say, we're going to run basically whatever you want to get paid. This is what we're going to tell you you're going to get paid. So they're going to be looking over that. But there's going to be a lot more. I know of at least 3 or 4 other places where the discussions are going on. And we could end up with maybe 10 or so hospitals, only hospital systems in this state. And it's not just Tennessee. Believe me, we are behind the 8 ball or behind the times on a lot of these things because other states are well on their way. The Medicaid cuts are going to continue on. We've got to come up with a solution, a different way of providing the care because that is just going to get worse. And expenses, including labor and pharma, are going to continue on. So, what are some of the solutions to all this? Again, we got to talk about the fundamental problems and incentives. Got to move away from fee for service. Is it a single payer? I don't know. I don't know if that's the best way to go. I can tell you that in this state, one of the things I look at is we have 3 managed care organizations that run the TennCare program. When they started that back in 1993, TennCare program was $2.5 billion, which was a big number. But administrative costs, if you go with 15%, you can do the math, but I'll go with 10%. So it was $250 million to run it then. Well, now you run that camera forward. We're now at a $7.5 billion system that's out there. And if you put administrative costs even at 10%, you're looking at $750 million. Now just think what you could do with that kind of dough if you had it and in terms of giving it back to the state, doing some innovative things, whatever it is. But in any event, it's, again, because you're going to gore somebody's ox, it's a real hard thing to get there. We got to continue to focus on the patient. I mean, that's one of the things. We can't keep sending out these ridiculous bills. We got to have better outcomes, and certainly we got to improve our customer service. A lot of systems are getting there. They're really working on trying to do that. Next thing is that quit shooting at each other. Let's try working together. Wouldn't that be fun? What a concept. And I don't know. We'll have to see how that goes, but certainly the main thrust has got to be working towards controlling cost. Get the consumer confidence back again. We're not the bad guys. We still take care of people. And finally, got to get that innovative ideas how to change the system and look at the continuum of care. Get it from when the patient comes, before they hit the door, to when they leave the door, or even after they've left the door. So, we'll see where all this lands. But one of the things I just leave you with, and this is kind of more of a personal thing, but I have my grandmother was Elsie Larzalier, and she was 1964. She went in the hospital. She had chest pains. Clearly, she had clogged arteries. They couldn't do anything for her, so she went in the hospital to die. So you roll that camera forward to, I guess it would have been 1994. And my mother, Pauline, she goes into the hospital with the same thing. She's got to have open heart surgery, and that's what she does. She gets the open heart surgery. I had her with us for another 15 years. She was in great health, everything all the way to the end. Same thing with her son. Roll that camera forward, until 3 years ago, I ended up with clogged arteries. I ended up going to the hospital, and I plan on outliving my mother. So, I guess what I'm saying here is that we can't, we got to make sure that we don't throw that kind of good stuff out, and we don't lose the concept or the ideas about what it is. And that all came about through innovation. And I really believe in my heart of hearts that we can do it. I think we can make this system better, and I think it will. But boy, we need a lot of help from our friends at government, a lot of incentives to move us around. So let me stop there. I know I'm sure I'm up against the time, but any questions or anything comments anybody got? Yes, sir.
There's a lot of talk about trying to instill more market incentives, and we're all market people, but it strikes me that medical care is not strictly a market good. In other words, I can't afford a Lexus, I'm just not going to buy one.
Right.
But if I can't afford health insurance and I break my arm, you're not going to turn me away.
Right.
So it's not strictly a market. I don't think we want it to be strictly market-based. So if you had a clean sheet of paper, how do you address that in an equitable way?
Well, here's the problem. I mean, let's use a supermarket one. You go in and buy a loaf of bread, costs $2, right? Whatever, let's just say $2. You go into healthcare and you use the same thing. Somebody may pay, if you're a Medicare patient, you're probably going to pay $1.60 for that loaf of bread. If you're a Medicaid patient, you're going to pay maybe 80 cents for that loaf of bread. If you're no pay, you're not going to pay anything for it. You're still going to get that loaf of bread. And worse yet, if you're a commercial payer, you're probably going to pay $3 for that loaf of bread. So that's the market right now. I mean, that's how crazy it is. So to me, again, I think where it goes is you go to this, as I say, this capitation rate, where you go and you say, okay, whomever, whatever hospital or whatever system, you all are going to be responsible for this many patients. And you got them from soup to nuts, from birth to death. And we're going to, everything that happens to that person during that year, you're going to have to take care of them for that kind of money. This is what goes on in Europe, and I know a lot of people say, oh, that's terrible what's going on here. It's not. I mean, it's a great system over there. It's really not that bad, and that's how they operate. They make it work because they know that they have to keep those patients out of the system. So, I think we're so far gone, I don't see how we can go back to a purely market-driven, especially when the federal government is so involved in this thing. Yes, sir.
I recently heard about a small town in West Virginia, 2,300 population, fulfilled prescriptions for 900,000 opioids.
Oh, yeah.
That's
crazy. Well, you go up to Jamestown. There was a highway went into Jamestown. It came straight from Memphis right up there. It was the same thing. It was they just had these tremendous amounts of things on the opioids. One of the things that we finally, I think we've got the attention of everybody on is the opioid problem. Now you come into an emergency room now, and we've got basically a policy that we've got most of our hospitals on. You get 5 days. That's it. Nobody's going to give you 30 days anymore. And there's a registry that you got to go in and check and see if that person has been, shopping around, which is true. Now, you got to be careful with that because you got somebody who's got cancer or they got real problems, and they're legit reasons. I think that's just the start, though. I mean, we got to do education. we got to have the services to get these people off of it because, all right, I live in Brentwood, which is probably one of the most affluent communities in this state. And they said, the hospital said, you know, we used to see a lot of opioid problems come through. And these were Brentwood soccer moms. We're not talking about, you know, derelicts off the street. Now, the latest thing is since they can't get their opioids, they've turned to heroin. They're seeing more heroin coming in, which is just, and we've had more fentanyl deaths in our community than you can shake a stick at. So it's multifaceted again, and you know, until we get our arms around that, that's going to be the piece. Yeah, sorry.
You mentioned that doctors are either having to form larger groups or being hired by the hospital.
Right.
When they get hired by the hospital, are they taking a significant pay cut?
Not necessarily. It just depends what the specialty is. What they get is they get the support of that hospital. You know, there's incentives that have to be provided because, again, back the first time we went around this, we just hired all these physicians and didn't put any kind of incentives. So the first thing they came in and said, I want, you know, 8 weeks vacation and I'm only going to work 6 hours a day, and so forth and so on. So you have to have incentives in there. But the salaries are very good and they don't have the stress. Most of the physicians that I've talked to who have been hired by hospitals love it because they don't have to deal with all the rigmarole in the back, and they'll take a cut and pay just to have a quality of life if they can. Of course, now we've got these, you know, the EHRs, the electronic health records. We've got to fix that one now because they're spending so much time with their faces buried in their computers as opposed to talking to the patients. But I think on the whole they like it a lot better.
Well, that brings up another question. How big a role is technology going to play in solving this problem?
You know, if it's done right, it'll do it. I mean, I can tell you that there's one of our hospitals developed this system, and my wife is a nurse practitioner, retired now, but it would drive her crazy because the system that she did, she'd punch a button and then it would take her to like 6 different screens, which is crazy. I mean, a physician who's in a hurry or a clinician who's in a hurry, they want to push one button, they want to find out the face sheet, what is this person, and what was the last complaint that they had. That's basically what they need. And so we don't need to be too fancy about it, and that's where we're not quite there yet, but I think we're getting there. But I think it will play a role. And I'll tell you one of the things we're doing at the association, and I was telling Clark this earlier, that you know, we're a lobbying organization, but I can see 5, maybe 10 years from now, that's going to be probably a minor thing that we'll be doing because it's going to be so hard to get consensus to do things. But the thing that we can do, and I think that everybody needs, is data. And we are the data repository for the state, for the hospital data. And so one of the things we're doing is that as you're admitted to the hospital, we'll send out a notification to your primary care doctor and to your insurer to let you know that. And they should jump on this right away and say, okay, what do we need to do to have follow-up? Well, we make sure they have their drugs, make sure that they have a follow-up appointment. And that's where I think that it's really going to make a difference. Yes, sir. Either one?
Is there any ability to increase the amount of, I guess, consumer-driven competition based on price and letting the consumers of healthcare know on the front end?
Absolutely.
I think, you know, medical care is the only thing I purchase that I have no idea
Right.
what it costs until 8 weeks later.
Right. As I say, it's complicated, but here's where it goes. If you're insured, okay, we're talking about somebody who's insured. So you go to the hospital. Depending on what insurance company you're with, what your plan says, and what there are now companies out there that are working with. In fact, my youngest son is working for one of these companies, where if you I go to St. Thomas. So I go into St. Thomas. They're going to tell me, okay, not so much how much my thing is going to cost, whatever procedure I'm going to have done, but they say, here's what your cost is out of pocket. When you leave this hospital, this is the bill that you're going to get from the hospital. And it's even funnier is that, you know, when I went in for my procedure, they said, and if you pay today, we'll give you a 20% discount. So, you know, that was pretty neat. Now, part of the problem is you got a lot of independent contractors. We can't hire radiologists, anesthesiologists, pathologists, or ER docs. We just can't. We're not allowed to do that under the law. Don't ask me why. So they had a good lobbyist, I guess. So you're probably going to get a balanced bill from them. And they can still do it, but we'll get the blame for it, of course. But so that's where it gets complicated. I think the hospitals now are getting much smarter about it and saying, okay, here's what you're going to get from us, being, you know, the hospital. But we got these other independent contractors out there that we don't control. And that's where is wrong. That's wrong. That needs to be fixed. And actually, we have legislation prepared to try to fix that. But let me tell you something. I've had some really angry doctors in my office, and I worry about whether they're packing or not, let me tell you. I'm sorry, go ahead.
I was curious if you might have seen the headlines about the CVS Aetna rumored merger.
Yeah, I did. I read that just today.
And it
Yeah.
sounds like that could happen as soon
Yeah.
as next week.
Yeah.
From the perspective of hospitals as well as general health care,
Sure.
do you think that would be a positive event or anti-competitive or?
Well, you know, I'm not a big, the walk-in clinics I think are a great thing because that's primary care to me, and primary care is really a hard thing to come by, and it's generally cheaper, faster, everything else, because you go to our emergency room for primary care, that's the wrong place to go. So I'm a big fan of that. I haven't figured out what the synergies are between CVS and Aetna, but there's obviously something that they're thinking there, and I'm not sure what their strategy might be. You know, I think that the one thing though that would be good if you could get hospitals and the payers together. I mean, it would. And if we go to a capitated system, we're going to have to get to that point because the insurers do not provide care very well. I mean, that's one thing I've learned. Hospitals are even worse when it comes to being insurance companies because generally they have to tell their medical staff no, you know, that we're not going to give you a raise or whatever. And that doesn't generally work well. So it'll be, again, I'm fascinated with why that's going, except the fact that, you know, everybody feels that, oh goodness, we better buy an insurance company or get bigger or something. I don't know. Anything else?
One more quick.
Yes, sir.
I think Cleveland Clinic is messing around with remote diagnostics using, you know, you guys, do you have hospitals that are experimenting with that as well? Like,
not too much. Telehealth is about as far as we're getting. You know, I saw a really interesting out in St. Louis, the Ascension system out there has this, it's called a virtual hospital. I mean, it's probably, I don't know, 30 or 40,000 square feet. And they have all these monitors, TV monitors, and there's people actually in there that are doing it, and they're doing diagnostics, and they're doing primary care there for people out in the farms, you know, that are far away. That, I think, has the potential to get there. I can tell you with telehealth, my story on that one is I was at West Tennessee Healthcare, and they said, hey, you want to see how this works? And I said, sure, great. So we go in, and we go there, and it's this doctor, and he's sitting in front of a computer screen, a big screen, and then the other end is this guy, and he's got his bib overalls on, and he's got a problem. So he says, well, you know, I said, can you help me out? And he said, well, I said, let me see it. So he takes off his bib overalls and he sticks his butt right up into the screen, and he's got a big old boil on there. And I'm going, okay, that's enough. I don't need any more. I said, if you can get Bubba to do that, I'm like, hey, telehealth can work. It can really work anywhere. But I said, man, that was way too much for me. That was more information you needed, wasn't it? That's right. Yeah, right. Yeah, well, Clark and I could tell you some stories, some hospital stories that probably top those. All right, what else? Anything else? All right, it's been a pleasure talking with you all, and good luck with going on. I like the idea of the charter thing too. That's really a good idea.
Thank you very much, Craig.
Thanks. Appreciate it. Thanks. My pleasure.